If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. In today's episode, we'll look at the NICE updates published in June 2025, focusing on what is relevant in primary care only. We've got another short episode today, as there's only one updated clinical guideline relevant to us, the guideline on headaches in people over 12. Right, let's jump into it. The update to the guideline makes only one very small change. NICE has changed the strength of recommendations on migraine prevention. Now, topiramate and propranolol are considered options alongside amitriptyline, whereas previously only amitriptyline was a considered option and the other two were actively offered or recommended. This change better reflects the balance between benefits and harms with these three medicines. And that's it. So, given how straightforward this update is, let's take the opportunity to review the overall management of migraine. And we will start by saying that headaches are amongst the most common neurological problems seen by GPs. They're debilitating and a major cause of time off work or school. They also represent a substantial burden on society. We classify headache disorders either as primary or secondary. The cause of primary headaches isn't well understood, so we group them by clinical pattern. The most common primary headache disorders are tension-type headache, migraine, and cluster headache. Secondary headaches are due to underlying disorders. Examples include medication overuse headache, giant cell arthritis, raised intracranial pressure, and infection. Medication overuse headache often occurs in people already taking medication for a primary headache. The greatest health and social burden of headaches is caused by primary headaches and medication overuse headache. Additionally, many people with headache don't have an accurate diagnosis. Diagnosis can be difficult, and there's often concern about possible underlying causes from patients and also healthcare professionals. By improving recognition of primary headaches, we'll manage headaches better, improve quality of life, and reduce unnecessary investigations. Now, let's review the acute treatment of migraine with or without aura. For these, we should offer combination therapy with an oral triptan and an anti-inflammatory tablet, or alternatively, an oral triptan and paracetamol, depending on our clinical judgment. For people aged 12 to 17, we'll consider a nasal triptan instead of an oral one. Currently, this is off-label in under 18s, except for nasal sumatriptan. If someone prefers to take only one medicine, we'll consider monotherapy with an oral triptan, an anti-inflammatory tablet, aspirin at 900 mg, or paracetamol, depending on their circumstances. And again, for 12 to 17-year-olds, we'll consider a nasal triptan. Because of the link with Reye's syndrome, we should not offer aspirin to under 16s. When prescribing a triptan, we'll start with the lowest cost option and try alternatives if it's not effective. We should consider using an antiemetic alongside other acute migraine treatments, even if the person doesn't have nausea or vomiting. If oral preparations or nasal preparations in young people are ineffective or not tolerated, we'll consider non-oral metoclopramide or prochlorperazine. If we do use one of these and an anti-inflammatory tablet or triptan hasn't been tried, we'll consider adding one. We need to be aware of special warnings and precautions for metoclopramide and prochlorperazine as per the BNF, and we should discuss the benefits and risks with the patient. At present, only buccal prochlorperazine is licensed for migraine. Other preparations are only licensed for nausea and vomiting. Rimegepant, an oral calcitonin gene-related peptide or CGRP inhibitor placed on or under the tongue, is recommended as an option for the acute treatment of migraine with or without aura in adults, only if at least 2 triptans were tried and they did not work well enough, or triptans were contraindicated or not tolerated, and non-steroidal anti-inflammatory drugs and paracetamol were tried but did not work. We should not offer ergots or opioids for acute migraine treatment. Now let's turn to prophylactic treatment. We will consider propranolol, topiramate, or amitriptyline to prevent migraine. This decision should follow a full discussion of benefits, risks, and sustainability. We will take into account the following factors. People with depression and migraine could be at increased risk of using propranolol for self-harm, so we should use caution when prescribing it. We'll follow MHRA guidance on topiramate. It should not be used for migraine prophylaxis in pregnancy or in women of childbearing potential, unless the pregnancy prevention program conditions are fulfilled. That includes using highly effective contraception. The link to the MHRA advice is in the episode description. For amitriptyline, we need to follow guidance on the prescribing of antidepressants and the management of medicines associated with dependence or withdrawal symptoms. Currently, topiramate and amitriptyline are unlicensed for migraine in children and young people. If the first prophylactic treatment doesn't work or isn't tolerated, we should discuss trying another. If necessary, we move on to the third option unless there are safety concerns. And as we say, this applies to amitriptyline, topiramate, and propranolol. We will not offer gabapentin for migraine prevention. If all three options, propranolol, topiramate, and amitriptyline, are ineffective, not tolerated, or unsuitable, we'll consider a course of up to 10 acupuncture sessions over 5 to 8 weeks. We can also advise that the food supplement riboflavin 400 mg daily may help reduce migraine frequency and intensity for some people. Calcitonin gene-related peptides, or CGRP inhibitors, are recommended for preventing episodic or chronic migraine in adults with at least 4 migraine days per month, but only if at least 3 other preventive medicines haven't worked, aren't tolerated, or are unsuitable due to safety concerns. Of these agents, only atogepant is oral. The other are injectables. As we said earlier, rimegepant is another calcitonin gene-related peptide inhibitor, which is recommended for preventing episodic migraine in adults who have between 4 and 14 migraine attacks per month, but only if at least 3 preventative treatments haven't worked or are unsuitable. It is not recommended for chronic migraine. Let's remember that episodic migraine means fewer than 15 headache days per month, and chronic migraine means 15 or more headache days per month for more than 3 months. And in summary, atogepant can be used as prophylaxis for both episodic and chronic migraine, whereas rimegepant only for episodic migraine. Once prophylaxis has been given, we'll review the need for ongoing treatment 3 to 6 months after starting it. We'll stop calcitonin gene-related peptide inhibitors after 12 weeks if the number of migraines hasn't reduced by at least 50% in episodic migraine or 30% in chronic migraine. We need to remember that we will not offer combined oral contraception to women and girls with migraine with aura, and for predictable menstrual-related migraine that doesn't respond to standard acute treatment, we'll consider frovatriptan or somitriptan on days when migraine is expected. These are currently off-label uses. During pregnancy, we'll offer paracetamol for acute migraine. We can consider a triptan or an anti-inflammatory drug, but only after discussing the need and the associated risks. If prophylaxis is needed in pregnancy, we will seek specialist advice. So that's it, a review of the NICE updates relevant to primary care, including a review of the treatment of migraines. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.